Y-90 is really different. We think a lot of times when we're injecting things into the liver, we're doing it because it cuts off the blood supply. Now, the liver is the only organ with two innies. It has an artery that goes in and a vein that goes in, and it has a vein that comes out. Now, it turns out that the cancer likes to live on the artery, and the liver's perfectly happy living off that vein. And so we take advantage of that by sneaking catheters in, interventional radiology, cowgirls and boys, sneak in catheters and inject stuff. And our initial belief was that we're just choking the blood supply off to the tumor, okay? And that's embolization. And then we said, let's throw a little chemo in there. That's chemoembolization. Well, Y-90 is actually different. It is small particles, but those particles are bathed in radiation, yttrium-90. And instead of it being sort of blood vessel choking, they just sort of hang up in the tumors and radiate inside out. So think of it as long-term, about a month-long radiation, low-level radiation, delivered directly into the liver inside out. That's important because it's not embolic. It also means it's a lot less toxic. There's a lot less pain, nausea, fever, infection associated with it. But as oncologists, we have to understand that mechanism because with almost always when we radiate a GI cancer, we like to throw a little 5-FU in with it. So I almost always will use capecitabine for a month or so around the time of the injection of the Y-90 because I'm doing synchronous sensitization. So think of it as low-level chronic radiation, not embolism. Now, it does cause some liver hypertrophy. So we know we want to do that sometimes to do liver resections. So it's not useless in that regard, and so early Y-90 might convert some patients to resectable because of concomitant liver hypertrophy.